Hello, my colleague. Can I start?
Yes, please.
Yes. My experience in spine surgery is about 30 years. We perform all kind of surgery, open surgery, cervical, thoracic, lumbar spine, degenerative disease, tumors, inflammation, deformation, and all my life I think how to make my surgery less traumatic, easier, more cleaner. And first I start like Dr. Hassan from transforaminal endoscopy. Thanks God, I know Mr. Hoogland, Thomas Hoogland. I seen his presentation. I have been in the hospital and can see transforaminal endoscopy. It's a really good method, but it's a really good method for young people, for people who don't have a long period of low back pain. When I perform to all people this kind of surgery, transforaminal endoscopy, I have about 10% recurrent herniated disc. I start to do and how to, it's not possible to make transforaminally spinal stenosis. And I think what I can to do, especially for foraminal stenosis, because population start to be old, more old and more old. My UBE experience start from my first meeting with UBE was from 2019, when I, with my colleague from Kiev, from Rivne, visited the clinic Dr. Son in the Busan. My first opinion was it's not difficult to do microdiscectomy by UBE method. It's not difficult to do spinal stenosis, but when I come back, start to do it, I understand that this method have many pitfalls. The first, I have to prepare special equipment. After that, try to do it, try to visit another clinic with my colleagues, start to do, and I spent a lot of time. My first surgery was about 2 hours to microdiscectomy, 2 and more hours. And sometimes it was impossible to do it. Thanks God, Dr. Son, my first visit, Dr. Son in Busan, and Dr. Park in Dijon. Dr. Park and Dijon. I have certificate, I have good knowledges, but when I start to do, I understand I'm not good in this surgery. We visit the next time Dr. Son in Busan in the another clinic. He teach how to do many tricks, how to do it. I visited many conferences the last year. This year I have presentation in the grass where I meet Dr. Hassan and Юра, можно це забрати? Just one moment. I start to do UBE regularly since 2021, 2 years. The first year I perform only 38 cases. The last year I do 185 cases. You can see what level, how many cases. Converse to open surgery in case disc herniation was 3 cases by bleeding. Converse to open surgery in stenosis, 1 case. Why I didn't do endoscopy 2 years? Open surgery is more familiar to me, and I always worry: is it good method? Is it not good method? But now I perform endoscopy. Так, stop. Oh, yeah. What is UBE method? spinal endoscopic surgery, unilateral biportal endoscopy, minimally invasive procedure, two-portal system, one portal for endoscope, the other for instrument, similar to arthroscopy. Surgical anatomy approach and indication same like in microsurgery, decompression and lumbar interbody fusion. Basic concept is triangulation in multifidus triangle. Once we have speech with Dr. Son, my teacher, in the restaurant, when he eat Korean food by sticks, special stick, he told, our philosophy of triangulation, where we take this map, triangulation in our hair, because we eat we like it by sticks and always use triangulation. Next step. Why do I choose UBE? The first, neural decompression. First surgical goal in the degenerative disease is method equal to microsurgery. More clear operating field than in microsurgery. Minimal invasiveness. Preservation of back muscles, bloodless procedure, very low VAS score at immediate post-operative and early come to back everyday life. Differences between microsurgery and UBE surgery. In microsurgery, we have different two space. One destructive space pathway and the compressive way. In UBE, thank you. In UBE, we have only one space, our traumatic pathway, a same space for working and decompression. You can see in this video destructive pathway in microsurgery, big operating area, retractors, and here pathway to the working area in UBE. Retractor wide initial working space, and we have good viewing. Next. Different look. It's really necessary in UBE. When we look by microscope, less is outside. Soft tissue, incised and widely dilated. In UBE method, lens is outside. Here we can see all operating area, contralaterally view, central part of your working area, ipsilateral view. It's in a video from spinal stenosis. The history of biportal endoscopy started in 1996. De Antoni, the first translaminar epidural endoscopy innovation period. It's a Korean team prepare concepts, position change, surgical anatomy, tools, and the wide indication for UBE method. Prepare UBE method. In the Korea endoscopy, biportal endoscopy has two methods: UBE, unilateral biportal endoscopy, and BES, biportal endoscopic spine surgery. It's have small differences because UBE like to make spinal stabilization. BES technique, they prefer just only decompression. And stenosis period. Stenosis period, when they start to treat all degenerative disease. This herniation, stenosis, to make fusion, start to treat by UBE method all part of the spine, cervical, thoracic, lumbar spine. Maybe in the future, this method can replace open surgery. UBE concepts. unilateral biportal endoscopic surgery. Endoscope and the instrument move independently. It's different from monoportal endoscopy, from stenoscopy. Fluid medium surgery. Controlled continuous fluid from hydrostatic pressure. Triangulation. Semitubular system at working portal with semitubular retractor. It's really necessary. Dr. Son always told use semitubular retractor is obligatory during UBE method. When I start to UBE, sometimes a little bit later. Так, one hand surgery, you have to understand about it. When you treat your patient, you can take carries on to the left hand, to the right hand. In this situation, you have to work just only one. When you are a right-handed surgeon, just only one. Right hand can perform every step during surgery. Так. No support with another hand. Lens inside body. It's really necessary. Lens to be movable, not fixed. I show in the last video. You can put your endoscope at every angle of your working area. Pivot movement. UBE equipment. What instrument you have to do UBE? The first endoscopic system, 0-degree endoscope, 4 millimeter, bore drill with sheath, 4 and 0.2 millimeters. Radio frequency system, spinal probe, irrigation system, specialized UBE instrument, rotatory 2 millimeters and 3 millimeters Carrison. It's really necessary rotatory or really necessary. General spinal instrument. Now you can see equipment what use Dr. Son to UBE. It's detacher, it's dilators, it's semitubular retractors, and another instruments it's used for UBE fusion, and the video system. Next, UBE setting operation. UBE setting and surgical stuff by Dr. Son. Prone position in the working, in the operating table. It's place of surgeon. It's place to the nurse, scrub nurse. It's place to the assistant. Assistant is really necessary. And another C-arm, scope, saline area, anesthesiologist area, and the radio frequency equipment. About slightly, a little bit about hydrostatic pressure. Yeah, something. Yeah. Do you remember that the pressure in the epidural vein and the bone is about 15-25 millimeters hydrograph? When you put saline higher, about 50 centimeters back of patient, we can get pressure in the working area about 30-50 millimeters in working field. What you have after that? Stop bleeding from the vein at the really low bleeding from the bone. It's really good idea. It's really work. Once we asked Dr. Son, why you don't use arthro pump? He told, gravitation and hydrostatic pressure create God. Arthro pump create people. I believe God. I don't believe people. It's really enough. You don't have use pretty expensive equipment. It's a really good idea to work. assistant is really important to hold UBE retractor, and after that we have good outflow and good view in the working area to control working flow by closing existing tube during surgery. All part of spine can be treated by UBE method. Paramedian herniated disc, median herniated disc, foraminal herniated disc, lumbar part, thoracic part, cervical part. But all you have to start when you want to start from the lumbar part. Why? It's really easy. It's not so dangerous like thoracic and cervical part. UBE basic anatomy and posterior interfascicular approach. Now I want to speak about Dr. Son triangle and Dr. Son space. It original Dr. Son space, he give permission to use this several his slides. Theory of UBE, its preservation, damage paravertebral muscle, especially musculus multifidus. Musculus multifidus, it's a traumatic enlarged initial working space, doctor space. You perform it by semitubular retractor during surgery, and it's widened to potential space, interfascicular and above laminar space with semitubular retractors. It is key of minimally invasive surgery and tip to prevent UBE surgical complication during UBE surgery. Why the disc hernia is better to start UBE? It's the most familiar surgery. One, you always have more cases. It's less operating time because spinal stenosis always take more time. And the best way to study tool equipment for UBE. When you perform about 50 UBE herniated disc, it's a good idea to start to do spinal stenosis. Surgical steps for spinal stenosis by Dr. Son is skin point and triangulation under CR, initial working space, true working space, ipsilateral laminectomy, contralateral sublaminoplasty, ipsilateral flavectomy, contralateral flavectomy. The first step is 3 steps is specific in UBE. The last step is specific for open surgery, ULBD. To microdiscectomy, you can accept 3 steps. And steps 1, skin point and triangulation under CR, initial working space, true working space, early bone working of the base of spinosus process, latent exposed interlaminar space. After that, you have to do flavectomy like in a regular microdiscectomy, remove superficial layer and deep layer, and perform regular discectomy like in microsurgery. Before surgery, to UBE is really necessary analyze preoperative reading, analyze what bone structure you have. Abnormally anatomy in details, spinosus process, interlaminar space, another bony abnormality. You have to analyze how you have big lumbar lordosis, because when you have really big lumbar lordosis, it's really to miss your level. In this slide, you can see missed level, mismatch between real and comfortable triangle. You have to always understand how big is spinal lordosis, and you have to try use special equipment like maybe Williams frame to neutralize lumbar lordosis. In my department, I have Williams frame, but to me it's comfortable to use special pill and put it in near belt. Next, in CT, you have analyzed here you can see a normal anatomy. You have analyzed how big is lamina. You see differences, right side and left side, narrow lamina. Tip spur in the spinal process, joint spur, rotation and deviation spinal process. When you will start, it's the best idea start from the normal anatomy. Every level in UBE have some differences about target point, about how big is lamina, how big is lamina. The best idea start from the L4, L5 level and L5, S1 level. After that, go higher. And surgical steps for herniated disc. We will speak about every steps. The first step, skin point and triangulation under CR. Skin point. The first you have understand what is initial target point is junction between lamina and the stenosis process, lower one side of the lamina. Maybe I can. Буде, Юра, видно? Буде. А я не зможу показати. You have.
It's blurred, sir.
Good? No. Не треба. I show you a little bit later.
Okay.
Your target point is this area. Your target point always is this area. This area. This area. And after that, make two portal. Working portal, skin incision, lower pedicle, whole fascia, medial wall of the pedicle, lower pedicle, and scope portal, 2 and 0.53 centimeter cranially. In this picture, you can see where we make working portal and scope portal, and whole incision and fascia incision. It's a red line. Direction is to the initial target point. It's first landmark in UBE. LP, middle of your yellow line. Yellow line have to be middle between working portal and the scope portal, target point. In this video, you can see how Dr. Son do skin point and triangulation under CR. No, here. First, it's target point. Next, working portal. He stopped to 1 second. Why? He always made the CR control. What he do? After that, he insert fast dilator really gently. X-ray control, touch lamina, upper lamina. And after that, insert the next tubular retractor. A little bit later, I will and detach soft tissue from the spinal process and the lamina. And working, and the scope portal. Under CR, control, fascia hole, and insert dilator. And scope. It's not difficult, but you can get many problems that you wouldn't do it accurately. I show why a little bit late. Check position of your camera and insert scope to the working area. Posterior interfascicular approach. How I when I start this surgery, I make X-ray control because before skin disinfection, several steps. First steps, I indicate midline, L4, L5 level. The next step, I indicate target point. Next, skin incision to herniated disc, working portal, scope portal, and I check upper part of disc and lower part of disc. Under CR, like Dr. Son, I make skin disinfection, skin incision, fascia incision, insert dilator, small, touch upper lamina, stop, touch, just a moment, touch upper lamina, after that really then gentle touch lower lamina, after that insert bigger dilators, two dilators. Skin incision for to scope portal, and insert. You have organized meeting and feel by dilators everyone. We have organized meeting tip of dilators. Dr. Sor recommend to make skin incision and fascia excision the same to the herniated disc and to the spinal stenosis. When I do it, when I begin to do this surgery, really often I go contralaterally. And I think the best idea to make skin incision a little bit more medial. And fascia incision like Dr. Stone recommendation. Why? Scope will be more parallel to the body. Will be more parallel to the body. You will have better ipsilateral view. It's really necessary when you treat herniated disc, and lower risk of motion to the opposite. In it, the next step, when you insert, when you insert dilators, next step to prepare initial working space or Dr. Son space. You have to make muscle detachment by detacher and dilator 15 millimeters. Insert semi-tubular retractor to enlarge space and guaranteed water outflow. Hydrostatic pressure to enlarge space and conformate water outflow. Step by step. There you can see potential working space. There is potential space between lamina and back muscles. Why? Muscles is not good fixed to the lamina and to the lamina into the spinal process. And when you insert here dilators, it's really easy to detach muscles from the bone. After detaching soft tissue from the lamina, an endoscope inserted into this space and put the high hydrostatic pressure pushed soft tissue and finally make initial working space. Technique: bone touch fast. Stay only bony landmarks, scratching sounds and feeling of laminar surface. Why? You can see semitubular retractor, what retract multifidus and enlarge working space. In the video, it's look like here. You prepare initial working space. A little bit later I speak about. Sure? A range of soft tissue detachment for herniated disc. It's enough area of detachment. Why? Several pitfalls you can have in this step. Excessive detachment can create more bleeding. Remember about source of intense bleeding. Regular vessels, what can create a really intensive bleeding. Be careful during the interlaminar area detachment. In case having a wide interlaminar space, ligamentum flavum penetration may be caused and a dural injury. My case, several months ago, I think that I really have a pretty big experience, work really sure. You can see herniated disc, man, 65, herniated disc L4, L5, left side, really big man, and the thin. You can see how much I have interlaminar windows and spinal process deviation. During the introduction 5 millimeter delay, I felt into the spinal channel. I understand that I am too deep. Thanks God, without neurological deficit, without damage dura mater, but I was really afraid. I really end upset. How you can make soft tissue debridement? By shaping. I use it in case of a large amount of interlaminar fat. Sometimes it's possible L5, L5S1 level, but it's not good idea because shaving can create more bleeding. You have to remember about source bleeding, what we speak a little bit later. Radio frequency, it's really better. Radio frequency is really better. Like here. Remove soft tissue by radio frequency, but it can create muscle contraction and low temperature burn. You have to use coagulation and ablation mode short and multiple times. And you have to remember about hemostasis of the roof of the working space. Sometimes from the skin you can give bleeding. It will disturb you during surgery. It's better idea to stop bleeding when you just only start. Intense bleeding. What to do when you have it? Hold the tip of scope and radio frequency electrode together. You have to put together. Remove soft tissue around the scope tip. Remove semitubular retractor, just only to short time. Move scope to the more close to the lamina, touch lamina, and more to the bleeding source. And try to find the bleeding source focus, push, but radio frequency electrode and coagulate. Pitfalls in this step. Don't try to control bleeding with high inflow pressure. Why? You can get muscle swelling, outflow obstruction, and deterioration of the lesion. What I want to tell you like to beginners. When I start to do UBE, I do not use semitubular retractors. First several 5-10 minutes, I have good outflow, but after that, I have problem with our water outflow and have bad vision in the working area. I didn't know why it is it. It was by muscles swelling the fast. And the next step, I think it was anesthesiologist problem because sometimes then they do not control muscles relaxation. You have to work like good team with your anesthesiologist and always ask them about good muscles relaxation. The next step, true working space by Dr. Song. After drilling lamina, surgeon get a true working space which is above ligamentum flavum. What video? After you sit crop, you start drill. It's target point. It's your target, fast target point. True working space. What step you have to do during preparing true working space? The first, prominal partial laminectomy. Next step, lateral partial laminectomy. Next step, flavectomy of superficial layer of the ligamentum flavum. Next step, flavectomy of the deep layer of the ligamentum flavum. As a next step, distal partial laminectomy if is it necessary. For caudal migration disc. You have to remember about 2 layers of the ligamentum flavum in arthroscopic view. Superficial layer is thick, white, attached to the overlamina. And deep is thin, yellow, attached to the margin of the lamina. Deep layer protect dura. It have to be removed just before discectomy. What equipment you have in this step? Drill. I don't use really often shaver and rotated caisson. It's really necessary in this step. Usually drilling is not necessary to herniated disc. Possible to do it by caisson. When I start, I do it especially at the level L5 S1 and L4 L5. But you have to use drilling always when because it's really necessary to the next experience when you will have treats if you want to treat spinal stenosis. How much to remove lamina cranial? L5 as well level is about 3-5 millimeters, sometimes 0 millimeters. L4, L5 level, 5-10 millimeters. L3, L4 level and level above about 10-15 millimeters and more. It sometimes depends downward extension and in the what kind of migrated disc you have. How much to remove lamina laterally? It's a really interesting situation. Why? Because when you will go to laterally, you can to damage part articularis of spinal EAP, spinal inferior spinal process. Because when you don't have big experience, the best idea to check how big interlaminar window you have during your working by X-ray control during surgery. True working space. And just one moment. Oh, good. First step, working on the basis of spinal process. The next step, go a little bit laterally. Next step, a little bit down. Iatrogenic, you can see here in this slide, iatrogenic lesions of ER. When you can get this situation, high lumbar spine, level above L5 as well, L4 as 5, when you have narrow lamina, when you have severe central bulging disc, and when you have revision sagittal. Next step, phlebotomy superficial layer. Instrument, it's detacher, curettes, disconnect from the bone with a retractor, radiofrequency electrode, and carriage. And this video here, wait, let's stop. You, one moment more. You detach from bone superficial layer of ligamentum flaum. Phlebotomy deep layer. You have understand the anatomy, every region. Second important landmark in the endoscopic view is bony junction between lower lamina and sub. Bony junction. Lamina, sub. Transversing root is just below junction. And when you do, when you remove deep layer, in this area, you will have nerve root. Start from second important landmark in the endoscopic view, bony junction between upper border of lamina and medial margin of sub. Palpation, you can see, palpation of the medial and upper edge of the pedicle will show the need to expand the your incision cranial. Wait. Opa, stop. One more. Now I remove deep layer of the ligamentum flaum and palpate. After that palpate, medial border of the pedicle and upper border of the pedicle. And the nerve root is here. How much to remove deep layer for herniated disc? When you have posterolateral herniated disc, just lateral part. We have to remove just lateral part. Epidural fat will not interfere with the procedure. A lower disc of damaged dura mater. When you have central herniated disc, you have to perform total removal. The next step, discectomy. Posterolateral herniated disc removed by microronger, 2 millimeters, sometimes when you have big disc, 3 millimeters. Central herniated disc I try to remove by hook. Try not to use the root retractor, especially in case of medium disc herniation. You can increase neurological deficit. The best idea, first, remove, sequester by, just a moment. the best idea, remove sequester by hook, biggest part of sequester by hook, and after that you can use ronger, micro ronger. Pitfalls in this step. When you put your scope too close to the dura mater, you can create dura fold. Even we will try to medialize dura mater on ulnar root, you can damage dura or root. What to do to escape this problem? Removal of only lateral part ligamentum fram prevent the formation of dura mater. You make sure you see the lateral edge of the nerve root before retraction, like here. Really gentle, medialize nerve root. Disc irrigation. I always use disc irrigation when I finish disc debridement by ronger. I use blunt needle, Serhii 20 milliliters. When I have old patient, I usually have a lot of small disc fragments. Young patients, very often I have 1, 2, 3 big disc fragments after washing inter-body area, washing disc. I think it's a reduced number of early recurrences with herniation. One more video. Blunt needle, insert in the disc and washing. It's a regular situation. Very often you, after removing sequester, you have reduced pressure of the bulging disc on the nerve. I use coagulation mode 1-3 number. Yeah, I think it helps reduce residual pressure of the nerve root, like here. Insert probe in the disc and use coagulation. Not long period. About drain. I always use drain when I have a case of spinal stenosis. To herniated disc, I use about 10-20%. I just stop the flow water and wait about 20-30 seconds. If there is not significant bleeding, I inject steroid and finish surgery. I didn't have cases of clinically significant epidural hematoma. And several words about the beginner's fairs. The first beginner's fairs to me was converse to open surgery. Next, damage endoscope. To be lost in the jungle, Dr. Song jungle, lose orientation, and obesity patient. If you didn't have experience endoscopy, working with drill, with radio frequency electrode, with rotated Kerrison, it wouldn't comfortable to you. And the first we'll speak about converse to open surgery. I always think it's what is sorry. You're a change situation. Let's go. The first obesity patient. One doctor from my department to give me MRI control and ask, is it possible to do by UBE? I told it's possible, but why? When I seen patient in my operating table, I was really upset. But it's but after surgery, understand it's not so difficult like I think. During surgery, I don't know why I have good watering outflow, and it's understand after surgery that by UBE it's really easy to do like open surgery. But you have to have a long endoscope. Regularly, I have discoscope working length 140 millimeters, but for obesity patient, you have a little bit bigger, 175 millimeters. Так, the next fair, converse to open surgery. When we make skin incision, it's a regular skin incision. I worried about what I would do when I have to go to the open surgery. Don't worry it about. You can a little bit enlarge your working portal. Insert in this area your regular dilator, like a tubular retractor. In our department, we use Caspar equipment. You can insert Caspar retractor and finish this surgery by magnification like lens or like microscope. Damage endoscope. In this picture, you can see how Dr. Son keep endoscope. To me, it's not possible. I have to fix my hand to the skin of the patient. It's master position. It's beginner position. Fixing the hand of patient body avoids the movement endoscope during the surgery. It's lower risk to damage endoscope and lower risk to lose orientation in the working area. The next, my fire was lost in the jungle. Sometime when I start, I didn't understand what structure I see in the endoscope, where I am, where this pedicle, where this target point. Don't worry it about, you can check, position your instrument by X-ray. During surgery, every step, when you start to do microdiscectomy, when you will start treat spinal stenosis, you can check your every step by X-ray control. Cool. And thank you very much to your attention.
Thank you, Dr. Serhii Balan.
Stop to share.
You can stop sharing your screen.
Mm-hmm.
Thank you. Thank you.
Thank you.
Thank you for your inspiring lesson. I want to ask some question about.
No problem.
Do you use a mild hypotension for bleeding?
I didn't have enough time. What I want about bleeding? Fast bleeding you can when you prepare. I can get back or not to my presentation. No. The first step, you can have bleeding when you prepare working area. You have to remember about source of bleeding. You have only 3 vessels where you can take bleeding. You have to be really gentle when you detach soft tissue from the bone. In the way you have bleeding, you have to check every area near spinal process, near joints, and near upper lamina and saw. You have what is the best idea when you put your scope more close to the source bleeding. Mostly source bleeding start to be less. After that, you put probe, and you have to push probe soft tissue. Stop. After that, you will have stop bleeding, and after that, just only use radio frequency or use temperature. Do not try to use electrode back in different area. You have to understand where you have source of the bleeding and go directly to this area. The next bleeding, what you can have when you make a true working space. I didn't have time to prepare this slide. You have bleeding from the bone, and after that from the epidural vein. When you have bleeding from the bone, you have always use bone wax. It really works. The first idea why? When you drilling and have bleeding, always use bone wax. It's really easy. Stop bleeding, and in the way recurrent herniation, it's really easy to remove soft tissue from the bone without drilling. It's a good idea. When you have bleeding from the epidural vein, you can use coagulation, but just only mode 1, 2. Do not use 3 mode. And you can use special stuff for stop bleeding, like Serhii cell, unit cell, and another things what you have in your department.
Thank you. Thank you, Professor.
No problem.
Yeah.
Dear Serhii, I think the question was when the bleeding doesn't stop with easily, do you tell the anesthesiologist drop the blood?
Yeah, I always tell. I always use bleeding control drugs in your country, like what is your name? I always ask anesthesiologist about 2 things. The first, to make general pressure lower. The next step, use special drugs to stop bleeding. And always it's work. Always it works. I think they gonna to open surgery several times. Not it was not controlled bleeding. My position, my patient in the table was really obesity. It was, and the pressure on the vein was too big, and I cannot control bleeding.
Thank you.
If you like use Williams frame, do you use Williams frames in your department or not?
Oh,
no, it's a really good idea because belt go to the hole. It's you wouldn't have big pressure in the epidural vein, but it's not comfortable to work. Yep. You have to special equipment to stop.
We don't have, unfortunately. Yeah.
Yeah, I want to go to the discussion part. Dr. Mustafa Sadef says, thank you very much for your great presentation. I would like to learn something basic, yet not often found in textbook. Do you change the patient's position depending on pathology? For example, in a contralateral approach, do you tilt the operating table toward yourself or to the opposite side?
No, I didn't understand. What did you ask? I change my patient position.
Yeah, depending on the pathology.
Yes. Do you tilt the table?
No,
like
no.
Opposite side or
no?
Okay.
When you use open surgery, and especially when you use treatment, when you perform ULBD, it's comfortable to rotate patient to the another side when you perform contralateral decompression. When you use UBE, it's not necessary. you can put your camera ipsilaterally, contralaterally. It's not necessary to rotate your table. No,
Thank you.
it's really good method for this stuff. In my surgery room, I don't have rotating table. I perform in regular table, especially to X-ray investigation, cardiologic investigation. It's good, really good.
Fluoroscopy table you use.
Yeah, fluoroscopy table. Yeah, regular fluoroscopy table. It's more comfortable.
Yes. Professor Hasan Kamil Sucu says, thank you very much for your presentation, which is fully oriented to teaching and explains all these steps detail. This was exactly the conference we needed. And Amit Potere, sir, do you use irrigation pump or gravity dependent? It's already, I think.
I use only gravitation. Dr. Song told gravitation creates God. I more believe God than people. When I start to do transforaminal endoscopy, I use it arthro pump, and several times I have problems like neck pain, big headache when I have long surgery, more than 1 hour. After that, I start to use only gravitation. It's enough. When you want to increase pressure in your working area, you can take tank of the saline more higher. It's no problem. It's always works. Understand me?
Yeah, Professor, do you start at 50 centimeters, right?
Regularly 50 centimeters. But when I have not controlled bleeding, I ask my nurse to put it more close to the ceiling, more close, higher. 60 centimeter, 80 centimeter, but not long period. After stop bleeding, I put to the 50 centimeters.
Thank you.
Yeah, thank you. And Dr. Ertan Seven from our clinic, thank you for this detailed and visual presentation, he says. And one more question. With single working hand, is it difficult to do clean job? In large central disc, would you like to do approach from the both sides?
I never do it. I have a really, it's really, thank you to your questions, really interesting question. I always worried what to do when I have big central herniated disc, L5 S1 laminar, L4 S1 at higher. I have to do bilateral access. It's enough to do just only ipsilateral access. It's the what I think the main idea to access. I start from the clinic side. When it's more painful right leg, I start right leg. When it's more painful left leg, I start from the left side. The next, when you have big central herniation, I always remove all part of the ligamentum flavum. In sometimes I go a little bit contralaterally, but after that I use hook, 5 millimeters hook, and try to perforate
The annulus.
Annulus, yeah, and keep sequester and remove by hook. It's always works. Always works. I never go contralaterally. Never go. Just, but you have to compare MRI investigation, evaluate how big is sequester and how big sequester did you remove. I never go contralateral. Always, in my cases, I remove it every sequesters.
Thank you. Dr. Ayhan Kanat from Turkey. Thank you for your good presentation. You use much saline irrigation during procedure. What is the effect of irrigation on the post-operative fibrosis occurrence? What is the rate of post-operative fibrosis in your cases?
Thank you very much for your question. Now, my son, he works in my department, and he was investigation about your question. We make MRI control after 2 months after surgery and after 6 months after surgery. What I can tell you, you after UBE surgery, after saline good irrigation, we don't have big scare in the working area. Soft tissue is in the better condition like in open surgery, but sometimes it's depends. But mostly it's muscles and another soft tissue is in better condition like in open surgery. It's fast. And I have about 10 recurrent herniation, about 5 after me, after endoscopy, and 5 after open surgery, mine open surgery. Always it was really easier to do a microdiscectomy after UBE because it's like fast surgery. It look like fast surgery.
Right. Another question: how much is residual disc incidence and reduced surgery?
Oh, sorry.
How much is residual disc incidence and reduced surgery?
I told just, thank you for your question. I have 5 patients now. I had 5 patients. I am not sure. Maybe my patient go to another doctors. It's possible. But after about 400 surgery, I have just only 5. It's clinically significant. Clinically significant. What I make, what I reoperate. I don't have statistic really, but I think it's like regular surgery, about 5, 7, 8% after surgery. But I make reoperate only 5.
If there is a recurrent disc, do you prefer UBE or microdiscectomy?
First time I was really worried, and I make open surgery. My colleagues from Rivne, from Kyiv, from another region, my country persuaded that easier to make by UBE. I start to do UBE and I understood it's really easier, UBE. It's look like fast surgery, like fast UBE surgery. I would recommend to do it by UBE, but be really gentle with removed bone. You have to try to separate soft tissue from the bone by instrument without the drilling, and especially it's really easy when you will ask bone wax during stop bleeding from the bone.
Okay. And one more question. Is there any difficulties to detect dural lacerations or tearing by much saline water irrigation during surgery?
One more.
Is there any difficulties to detect dural laceration or tearing by much saline water irrigation during surgery?
The
Yeah,
question is, as I understand,
it's not.
sorry,
I understand it.
if the dural tear happened, it can be detected easily.
I am not sure how much I have dural tears, but significant dural tears. I have in disc herniation 3 times. That I seen it. I have what to do in this situation. Do you remember discuss Dr. Son and Dr. Hayati in GRASS?
Yeah.
Different view. Dr. Son think that you have to suture during tears. Dr. Hayati told finish surgery as much quickly as it possible. Sometimes it's I never try to suture during tears during surgery. I always use like Dr. Son Tahosil and Tahocom. Thanks God I don't have leaking from after surgery. I didn't have, but I have a little small dura tears, about 2-3 millimeters. Thank God it stopped after using Tahosil. I never use, but one doctor from Brazil sent me a video how he suture. If you want, I can send this video to you.
I know this doctor. He's doing monoportal surgery, right?
Yeah, monoportal and biportal too.
Yeah, I know. He is using.
But I never used it. Thanks God, it works. I try always why I have, but once I have problems, just when I start to do medialize dural sac, I damage dural sac. After that, I have really big central herniation, and I try to remove sequester. After surgery, my patient have difficult headache. I think because saline go to the dural sac.
I want to make a small contribution about the dural tear. I'm in Tashkent for the CASMIS meeting and there were some guys using endoscopy in spinal intradural tumors, and the guy using clips.
Clips.
Some clips for closing the dura. He cut the dura with knife, and then in the end of the surgery, he is using clips only to closing the dura. Seems easier, but it must be tried.
What kind of clips would you give me information about?
I can ask him by WhatsApp, and then I can send you the information.
Yeah, where I can buy it. I think it's really necessary because I always worry what I will do when I would have big dura tear.
He was cutting all the way long because it was the intradural meningioma cases. He was doing endoscope, and then in the end of the surgery, he was closing dura with special clip applier like this.
I seen this video. I seen this video in the internet, but I don't know what is clips.
Yeah, it must be tried. Yeah. And Efecan?
And one more question from Nurzan Borkbayev. Thank you so much for your presentation. My question is, when you remove a herniated disc, do you remove just herniated disc or entire nucleus pulposus? How do you prevent early recurrence of the herniation?
When we have early recurrent herniation in our country, people think that it's doctor mistake, that he doesn't remove herniated disc, because we always go into the interdiscal space and remove small part of the nucleus pulposus by small ronges. Always I use 2 millimeter ronges, but when I have really big high disc, sometimes I remove 3 millimeters. 3 millimeters. After removing, after debridement disc, I always use washing. Very often when you have young people, you use a ronger and remove ipsilaterally, contralaterally, and when I use washing about 30%, I wash pretty big sequester. I show it in my presentation. Pretty big sequester. I think it's prevent recurrent, early recurrent herniated disc. I'll always use about 100 milliliters I wash. I push down, high, contralaterally, ipsilaterally, and wash interdiscal space always. I after UBE, I have just only one inflammation problem last month. I always wash interdiscal space. I never had infection, disc infection. I never had. Thanks God, I never
had.
Thank you, sir.
The guy you
and excuse me, one minute. When I first time was in Dr. Son clinic, once he told, now we will see new method, disc irrigation. My colleague, Valentin Piontkovsky, do you remember him from the Rivne, told me, Serhii, you have to tell that you many years use this method. I didn't tell you, I shy, it's professor, I simple doctor. Valentin told him, Dr. Son, take hand and give me. It's a really good idea, especially when you have old patient. Young patient, it's not really often, but old patient, always many small pieces. It's really good idea. You will have better result after disc irrigation.
Thank you.
Thank you.
And the doctor you mentioned about is Lopez, right? Mateus Lopez from Brazil, from Sao Paulo. Yeah. He talked in İzmir Online Neurosurgery also. You can find his video in our YouTube page. He showed this video to us also. And I think there was a question, there was a part of the question of KR. He didn't or she didn't write name, whole name. The question was, if you have a recurrent disc herniation and insufficient disc removing, the means when you get complete the operation and then you understand you couldn't take off all the fragments or disc herniation. Is there any case like this? You complete the operation thinking all the things is okay, and then after that, tomorrow or the other day, you couldn't take all this herniation and you left. Is there any case like this in UBE in your patients?
I think it's possible. Yeah.
Do you have a clinically important case we are talking about, not silent disc herniations? But as I understood, there is no such case in your series. I mean, all your recurrent disc herniations happened after sometimes later.
Just only one surgery. I have One recurrent herniation I have after 1 month, just only one. Another, it was after 1, 2 years and delayed. Just only one. Thank God.
Thank you so much.
As I see, there is no comment or questions. Dr. Serhii, I want to thank you again for your very didactic and very useful pitfalls and pearls. Thank you, Professor Serhii.
Thank you very much. It was really a pleasure to speak with my colleague from Turkey, and I want to wish you good results in this method.
Maybe Professor Serhii come to İzmir sometime and join us to perform a surgery and show us his technique.
No problem. No problem. If you want, it's possible.
If you can find the time.
Yeah.
Because you are busy, I know.
I think it's, if you want, it's possible. It's not so difficult. I can go to you, maybe with my colleague, because my one doctor in Ukraine perform many ULIF, endoscopic stabilization. Endoscopic stabilization, it's really good in this method. It's younger and he is more brave. And sometimes I use just only 2 ULIF. I perform just only 2 ULIF, but I think he performed more 100 ULIF. It's really interested about this kind. It's possible we can go to you.
Is it Valentin?
No, it's Yuri Lonkowski. He didn't have presentation, but Valentin do it too. But I think Yura have more cases now. He had more cases. Yuri. Yuri Lonkowski. Yeah. But Valentin too. We can go to you. He will be happy.
Thank you so much. I have another question, and I want to thank you so much. You gave your time, and I want to thank everyone who joined us today, this evening. Hope to see you in Turkey or in Ukraine.
Yeah. And good luck.
Thank you so much.
Thank you so much. Bye.
Thank you.
Have a good night.